Hello.
Hello.
Hi, Poonam.
Yes.
Sorry, there was some network issue. I got disconnected.
Yes, no worries.
Yeah. Should we start?
Yes, absolutely. I'm ready.
Okay. Okay. Actually, Madam couldn't join. HOD Madam couldn't
No
join.
problem.
She had a IEC meeting,
Okay.
so she has asked us to go ahead.
Okay. All right.
I'm just sharing my screen for a moment.
Yes.
Is this visible?
Yes.
Yeah. To start with, very good afternoon, one and all participants. So here we have with us Ms. Poonam Bajaj. She is our esteemed alumnus with 2 decades of vast professional experience. Presently, she is associated with Sir H.N. Reliance Foundation Hospital, Mumbai as senior consultant physiotherapist. So we welcome Ms. Poonam Bajaj and we thank her profusely for accepting our invitation to support our alumni webinar series. So it is so kind of her to having accepted this invitation. Uh, so, our Ms. Poonam Bajaj, as mentioned, she is alumnus of BPT 95 batch. She went on to complete her diploma in rehabilitation from All India Institute of Physical Medicine Rehabilitation in the year 2002, and subsequently masters in physiotherapy from Florence College, RGUHS in 2050. So during this 20 years of her professional experience, she has attended several, she has updated herself with several certification courses, and she has done her observership training at Parkinson's Center of Oregon, USA in 2 years, that is 2007 and 2017. Sorry, 16. So she is certified in gait and motion analysis from Connecticut, USA, and she has presented several papers. One notable conference is World Parkinson's Congress in 2016 on post-traumatic Parkinsonism. So as I said earlier, right now she is affiliated with Sir H.N. Reliance Foundation Hospital as senior consultant physiotherapist. So it is so nice of you, Dr. Poonam, for having accepted our invitation and to extend our alumni webinar series. So on behalf of our HOD and our faculty members, I thank you for accepting our invitation. So over to you, Dr. Poonam. So what I will do,
Yes.
as I set up this, as I make you the host, you can just give a brief introduction. If I missed out any points, you can just tell, add to your credentials, and you can just introduce your workplace.
All right. I would like to thank you so much, Dr. Selvam, for inviting me to talk with in association with Mahe. Mahe is my alma mater. It seems definitely doesn't seem like 20 years ago that I graduated from there, but it is the place where I learned physical therapy. I began my journey as a physical therapist, and it's a bit of a dream coming true that I'm actually even talking via Mahe. And I'm truly humbled and honored that I am on this platform today. And I'm looking forward to starting with this meeting. You have given enough allocates, so I don't want to say anything. I just would like to say a couple of things about the hospital that I work in. It's a tertiary care hospital in Bombay. It is more than 125 years old and recently refurbished. It's the first private hospital of Bombay and now amongst the first green accredited hospitals of Bombay. Currently, we are even supporting COVID patients in partnership with the government. So I have pretty much always worked in this institute, except for, since 2002, except for a few short years when the hospital was not working in between for renovation. And that's when I did my master's. So without taking much more time, I will start with the topic. Is that okay?
Yeah.
Am I
Uh,
audible to
just
everyone? Yes?
Yeah, you are audible. Just one thing, as
Yes.
I made you the host,
Yes.
just see that if any participants are there in the waiting room, please admit them,
Okay.
because I have lost control in
I
admitting them.
understand. I understand.
Yes.
Okay. I'm going to just admit all.
You can mute others. You can mute others because there are some background noises.
Yes.
You can mute all.
Yes, I did that. I've muted all and I've admitted everyone. Okay, I'll do this by and by when as and when I can. I'll see if the message
Yes.
pops up, then I'll do it by and by.
Yeah.
All
You
right.
can share with the. You can start sharing.
Yes. Okay. So my subject for today is rationale in the management of Parkinson's disease. Now, we learn about Parkinson's disease pretty much in second year of physical therapy. So why revisit this seemingly basic topic? We, as physiotherapists and as medical and paramedical and allied health professionals, know that exercise is pretty much beneficial for all patients with Parkinson's disease. So why am I bringing this up today? I think it is important for us to know why we do what we do with somebody who has Parkinson's. And this is an attempt, a brief attempt over the next 1 hour or so, to look at the rationale behind the kind of exercise we prescribe to the patient. Now, the incidence of Parkinsonism worldwide is a poorly known thing. And this is a very well-known fact. A meta-analysis done, and I'm not saying India, I'm saying worldwide. A meta-analysis done in 2016 put the number of people in affected by Parkinsonism as 6.1 million. And this meta-analysis was done between 1990 and 2016. When I look at data from India, according to published data by Pratibha Surti, who's from NIMHANS, she's highlighted, in fact, the lack of existing data about the incidence of Parkinsonism. This is because there are pockets of information from various states, but there is no countrywide or worldwide index for knowing the incidence of Parkinsonism. But what has come out of these two meta-analysis or systematic reviews is that the incidence is increasing with time, decade-wise. So between 1990 and 2016, the incidence of Parkinsonism per population measured increased by a whopping 74%. Now that seems like a very huge number, but according to the data that was published, they said that lifespan has increased, data collection methods have improved, Syndopa is more accessible, uh, and various reasons. But there is clearly, it's not just that we're measuring more people who have Parkinson's, but people are living longer and people are able to connect to these data collection agencies. They say that by 2040, this incidence will rise by further 10%. So I think it's important that as physical therapists, we should delve into a little more detail into this neurodegenerative disorder and take it forward. Now, I'm going to be talking about idiopathic or typical Parkinsonism today. I'm not going to be going into the atypical forms. We all know this. Parkinsonism. Hello?
Yeah. Sorry for the interruption. The screen is not shared so far.
Oh, is it?
Yes.
Okay. Just give me a moment, please.
Yes. 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 Sorry for the interruption.
No, that's fine. Thank you. Visible now?
Yeah, visible now. Just a
I'll
request.
just make it into full screen.
Yeah, there are few participants who are raising hands.
Okay.
If you can permit any questions in between, that is fine. It's up to you.
Okay.
If any participants are raising hands, please have a watch on people raising hands. And if
All
anyone
right.
is asking them to admit themselves, please admit them.
Okay, I will do that.
Yeah, thank you.
Yeah. Okay. Is my screen clearly visible now? Hello?
Yeah, it is clearly visible.
Okay, lovely. All
Please
right.
go ahead.
Yeah, so like I said, just a minute, please. Yeah, so we covered this. Now, Parkinsonism has certain common features, and this is deterioration in balance and gait, fall risk and injuries, decline in physical activity, and a decreased quality of life. Please note that I haven't spoken about so far about the bradykinesia, the rigidity. We are going to talk about this absolutely in the next slide and through this entire 1 hour. But what are we concerned about? What is the patient concerned about? The patient who has Parky is concerned about his deteriorating gait and balance, about his falls, about his decline in physical activity and decreasing quality of life. So this is more important to the patient. And what are we more concerned about? We are more concerned about how we can get them. I'm sorry, there is people entering the meeting. Just give me a minute. Sorry, yeah. You hear me now? Hello?
Yeah.
Yeah.
We can hear you.
Okay. So my screen seems to have gotten stuck. Please give me a moment. Yeah. Now, so sorry about that interruption. Now, we all know that Syndopa or levodopa is, Syndopa is the brand name. We all know that Syndopa or levodopa is the primary drug of choice and is the most highly prescribed drug of choice. But we all know that the prescription for physical therapy or exercise is not as popular as the prescription for Syndopa is. Now, levodopa can improve rigidity, bradykinesia, tremor, and some gait parameters for sure. And it's very effective, as we all know. However, my slide here is to say what it can't do. It cannot change the ability of a patient with Parkinsonism to improve sensory reweighting. Now, we all know, and we are going to see in detail, that the Parkinsonian patient has a problem with proprioception, with perception and using of proprioceptive or somatosensory information. Levodopa doesn't help with that. It actually even increases the mediolateral displacement of the center of pressure, and this increases fall risk. This is not something that is commonly thought about when we prescribe Syndopa, or I mean, of course, we don't prescribe as physical therapists, but when a patient is prescribed Syndopa, I don't think they're made aware that their fall risk increases. And Syndopa, about the limits of stability, we'll be studying this in detail in a few seconds now. It improves forward limits of stabilities, the forward limits of stability, but it doesn't improve the patient's ability to use the motor strategies. It doesn't improve the stooped postural alignment and doesn't improve the velocity of movement in a patient. This is not to say that not to use Syndopa. Syndopa has been the primary drug of choice for several decades and will continue to be, and I think it's essential. But alongside Syndopa, we should also have an equal prescription of physical therapy for gait and balance, because for the patient with Parkinsonism, these changes are actually real. The inability to perceive proprioception appropriately, the inability to stay well within and correct parts of the limits of stability, the stoop posture, and these things are not being changed by the pill. So just a brief recap into limits of stability and the motor strategies that are required. So like you see here, this is the cone of stability, and this person is leaning forward in the cone of stability with his ankle strategy. The normal human being's cone of stability is roughly 8 degrees forward, 4 degrees backwards, and 8 degrees laterally. Now, so this is using, and this is the forward limits of stability. This is bending from the hip and using the hip strategy. And this is when the center of mass went outside the base of support, forcing the patient or the person to take a step so as to maintain their balance. So this is known as ankle, hip, and step strategy. And these are the most well-known basic balance strategies, that the motor strategies that are required to maintain balance. A person needs to maintain balance subcortically and definitely does not need attention or cortical attention whilst maintaining balance. So to repeat, there is the cone of stability in standing, which is 8 degrees forward, 4 degrees back. And if you were to see an AP view, you would see the lateral limits of stability. And this is what happens to the person when they become dynamic, when they start walking. So the center of mass moves forward, falls outside the base of support, and forces the person to take a step. And therefore, this is how we continue walking step after step after step. And this is a short video in our gait lab. You will see the light red arrow. I will point it out. Can you appreciate? Sorry. Yeah, look at this. As the person walks and weight bears, the ground reaction force vector, which indicates weight bearing, goes on increasing on the left lower limb, and then the weight shifts laterally and goes into the other leg. You can't see the GRF because that leg is not on the force plate, and back again as initial contact happens and goes all the way up. That's the ground reaction force vector, and shifting from left to right, step by step. I'm going to just quickly play that again so that it's a very light arrow, unfortunately. There you go, weight shift. And increasing, weight bearing, load bearing. And decreasing there as toe off is happening. Other leg is not on the first plate, so you can't see that arrow. There you go, load bearing, initial contact. So that's how the center of pressure stays within the limits of stability within the basal support and well within, and as soon as it falls outside the limits of stability, you're forced to take the next step, which is normal walking. Now, what happens in Parkinson's disease? The image on the right, as you see, the lady is well within the cone of stability, but in the typical stoop posture, you see how close she is to the posterior limits of stability? And this can risk falls. If you're so close to the edge of your limits of stability, then you obviously stand a high chance of falling. Now, it's very important that we appreciate this posterior, close to the posterior limits of stability, and therefore fall backwards is a risk. Sorry, every time I admit somebody, my screen gets stuck, unfortunately. Dr. Selvam, is there some way we can sort of stop admitting people now?
Yeah, as it Zoom allows only 100 participants.
Okay.
Yeah, so you need not admit anymore. You can
Okay.
just go ahead with the presentation, so that
Okay.
there is no.
Yeah, because every time I'm doing that, it's sort of my screen is getting stuck.
Unfortunately, there is no option of having a co-host.
I understand. Yeah, yeah. Okay.
So each platform has its own limitation.
I know. I completely appreciate that. Sorry, give me a
Yeah,
moment
in
while
case of yes.
I'll
Yes,
stop
yes.
sharing and start sharing again. Okay, so everyone, please bear with me for a minute. Yeah, is it visible now, Dr. Silva?
No, not yet shared. Not yet shared so far.
Okay, sorry. Yeah.
Yeah, it's
Okay.
about to start.
Yeah, sorry about that, everyone. Okay, so we were here and we're here now. So like I said, it's very important to appreciate the fall risk. And we know by statistics, not by just because I'm saying it, and here's the evidence that Parkinson's patients have a 9 times higher fall risk than elderly people of the same age. 9 times. And like we already discussed, levodopa is not a good treatment option for balance and gait impairments in Parkinson's. In fact, because it changes the lateral center of pressure mobility or the center of mass, it worsens balance impairments and it can risk falls. So patient's option is exercise, physical therapy, and for the things that levodopa doesn't address. Now, this is an important slide, so please understand this, because our whole understanding of why we do which exercise is depending on this. Why is balance in Parkinson's affected? There are 4 reasons, basically. Poor reactive responses. Now, imagine trying to cross a crowded street, say in Bombay, or I don't know, are there still buses from Udupi to Manipal, Dr. Selvam?
Yeah. Still
Yeah,
buses are there.
so
Yes.
those crowded buses, imagine being in one of those crowded buses, and the bus driver brakes and you're standing, And so this is a memory that just came to me, the ride from Udupi to Manipal. And so I'm giving you an example of that. You're standing in a crowded bus, and the bus driver suddenly brakes, and you have your cell phone in your hand, and you're on a WhatsApp text, or the cell phone rings, and you're trying to speak to somebody, and like I said, the bus driver suddenly brakes. Are you going to fall? No, you're either going to take a step and stabilize yourself, or if the brake was not too hard, you're just going to sway forward from your ankles, or you're going to do a hip strategy like we already discussed. So ankle, hip, step strategy, you may reach out and use the reach strategy to hold on to something. So those are reactive responses. Okay, so these are absent in Parkinson's disease. Or to give you another example, imagine crossing the road and the phone rings and there's a whole bunch of cars coming your way and you have to be really quick. What is the priority? You're going to cross the road or answer your phone? The choice is made by the basal ganglia. Now, the second thing that we spoke that is important here is lack of appropriate sensory integration. People with Parkinson's have difficulty using proprioceptive information that is given, and there is impaired proprioceptive information. People with Parkinsonism have poor anticipatory postural adjustments. Now, what do I mean in an everyday life example of anticipatory postural adjustments? So, if I were to just take sitting to standing as an example, what does a person do? You lean forward, you bring your center of mass forward, and then you push yourself up to stand. So the lean forward and bringing the center of mass forward is not a thought out action. It's an anticipatory postural adjustment. And this is what is missing in PD. Another example, if you want to turn, how do you break down a turn in your head? Okay. If you want to turn, you shift your weight onto one leg and then pivot on that leg and then place your other leg to stabilize yourself within the new base of support. So these lateral weight shifts are not there in Parkinson's patients. These anticipatory adjustments to shifting your weight onto one leg is absent or poor or smaller in amplitude. And then what we just discussed, the stooped posture, which reduces the, even if the limits of stability are available, the person is in the posterior area. And levodopa increases the available limits of stability, but doesn't help improve the ankle, hip, or step strategy that is required to negotiate that area in the limits of stability. So this is what we need to address. We need to help them get better reactive responses. We need to help them get better proprioceptive information. We need to help them get better anticipatory postural adjustments, and we need to help them improve their posture by using better limits of stability, by helping their strategies, their ankle, their hip, their step, not tell them to stand tall, stand straight. So this is important to know why we do what we do. And to repeat myself, this is in the posterior limits of stability, and we need to teach them how to use their motor strategies to get better. Now, I want to just briefly explain basal ganglia, what they do, because Parkinsonism is a dysfunction largely in the basal ganglia circuitry. Of course, dopamine, it's a neurochemical dysfunction. So there is an article that is titled "Of Subcortical Bottlenecks." A bottleneck, the in-demand bottles these days, a bottleneck is a narrow end of the bottle that allows only selective information to exit. What is the role of the basal ganglia in being a bottleneck. Now, I'll give you an example that was stated in this article. So all these articles are quoted, all these references and articles are quoted on my last slide. Please feel free to take a screenshot or photograph or anything. All the references I have used are written on the last slide. So yes, so what does the basal ganglia do as a bottleneck? The article says, now imagine there was a deer, an animal, drink in the forest, drinking water from the lakeside, and suddenly a lion comes and the animal is aware of it. Does the deer continue drinking water, or does the deer run for his life because the lion will chase it and kill it? So the priority of motor function, now this happens in split seconds or microseconds. If the deer were to think cortically, if that was even possible, it would take too long and it would be dead. Similarly, if we are crossing the road and the phone rings and there's a pothole in front of you, the priority to answer your phone, continue crossing the road with cars coming and avoiding the pothole in front of you, you obviously can't decide this cortically. You cannot think about what next to do. These reactions occur at a subcortical level, and the subcortical cell station, the basal ganglia, is what decides priorities. Hence, it is a function of the basal ganglia to have agility in deciding what motor action needs to be done. Also dual tasking, walking and talking, and maintaining interlimb coordination while the body is doing its multiple functions. So maintaining balance, maintaining coordination and agility, A, B, C. The agility, the balance, and the coordination is a large function of the basal ganglia. Now, let's go ahead and see how each of these symptoms of Parkinsonism affects mobility. Okay, so briefly, this is very basic. Delayed push-off, reduction of arm swing, increased time taken to generate the swing phase, reduction in the swing phase, a small stride length, all of these typical of the Parkinsonian patient. Now, what does it mean in terms of postural adjustments? That was gait, posture, and gait. So that was gait, and this is posture. Posterior center of mass, and therefore reduced limits of stability, inability to weight shift, and therefore poor ability to turn, and reduced sit to stand transitions because of inability to raise the anticipatory postural adjustments to bring the center of mass forward. Yes, these are all because of bradykinesia. In fact, this reduced ability to turn is seen in freezing. Patients freeze so often during turns. And this is one of the reasons why they can't shift their center of mass. Now, an example of being near the posterior limits of stability. That was a fall because the gentleman was so close to his posterior limits of stability. But it doesn't seem evident. Okay. So now let's examine the exercises that we do. There are so many reliable and valid programs for Parkinson's disease. For example, the Schenkman's, the LSVT or Think Big, Meg Morris's program. There are several that I may not even be aware of, but these I know for sure are valid and reliable programs, proven. There's strength training, there's gait training, there's gait training that I do, there's gait training that you do, there's gait training that a bunch of other people do. But what is important is that the exercise should induce neuroplasticity, neuroprotection, and slow down degeneration. What is important is that it has to be specific to the problem at hand, which means reactive postural responses, anticipatory postural adjustments, sensory motor integration, sensory reweighting, and posture improvement, stoop posture improvement, which will prevent them from falling backwards. Obviously, it has to be progressively overloaded because it has to get, we know this, the fit principle. It needs to get more and more challenging, and it has to be varied. You cannot have someone you work on APAs and you forget about the reactive postural control. There has to be varied practice. So let's briefly sum up what Parkinsonian constraints do. So rigidity causes, basically there's a lot of axial rigidity and neck rigidity. We know this. This causes a flexed alignment. This causes reduced trunk rotation and definitely part of the balance and gait problem. Bradykinesia causes small movements and the narrow base of support and therefore increases fall risk. Freezing happens at the turns because of inappropriate weight shifts, because it happens in narrow passageways, even because of a visuospatial map affection. The visuospatial map of the environment is also altered and also happens because of inability to handle dual tasking or multitasking. And there's impaired proprioceptive or kinesthetic awareness, and there is the inflexible agility. You cannot shift from one to the other. Like I said, the quick decision to run across the road, avoid the pothole, and not answer your phone, that inflexibility in switching motor programs. This is also seen in poor transitions in bed, in sit to stand, and turns. So that is because of poor anticipatory postural adjustments. This table has been taken from a 2009 article in Physical Therapy and is written in the references. So don't be stressed about this table. It's all there. It's all here. Now, what are the exercises? Literally, let's come down to the exercises that we're going to do and why. So we've all heard of the Tai-Chi. There's Wing Chun that's coming. There's kayaking. There's the agility course training. There's boxing. There's lunges. And there's pre-Pilates. Now, what each of these exercises does is basically helps the four things that we want to treat. Improving reactive postural adjustments, improving APAs. I'm repeating myself, but it's crucial for us to understand this. Improving limits of stability and improving kinesthetic awareness. Let's see how it does that. In fact, its progressions are also taught here. Okay, so let's have a look at each of these. Now, kayaking. Sorry. Kayaking is actually a sport and it needs a lot of trunk rotation. Not only kayaking, I think our Indian dances, for example, the Garba is involving a lot of rotations, which would really help in, I mean, that's only one of the dances that I know. I have no partiality to any form of dance, and neither do I have any partiality. Let me be very clear. I'm not here to promote a specific exercise program. I'm here to understand why these exercises are A, important, and B, why we do them. So kayaking, like I said, there's lots of reciprocal trunk movements. There's flexion, rotation, and protraction on one side, and extension, rotation, and retraction on the opposite side. There's a lot of the center of mass moving. There are reciprocal movements, as you can see, and you can go on increasing the challenge. Patient is first sitting, then standing with a wide base of support, and then standing with a narrow base of support, and then doing this on an unsteady surface. So go on increasing the challenge, and this will help improve your limits of stability, your lateral weight shifts, your sensory integration. Yes. Now, if I were to look at agility, high knees, quick lateral steps, okay? So like you see, the person here is doing agility training with high knees on an unsteady surface. This is the rehab department at the hospital, and is also dual tasking. So she was counting backwards from 100, subtracting 3. So 100, 97, 94, 91 whilst doing this. This is a Parky patient, and she's doing an agility course with high knees with a dual task on an unsteady surface. But if you notice, she's still visually dependent. So the next level of challenge, she's still looking down. The next level of challenge would be to make her do this with her eyes closed. I'm sure that would be difficult for a lot of us as well. Okay. So if I were to look at limits of stability on the right side, you can see, so this is a graph from computerized dynamic posturography. You can see a near normal limits of stability. What I mentioned, this is a graph. What I mentioned to you, 8 degrees forward, 4 degrees back, and 8 degrees on either side. And of course, this shows even diagonal movements. This test measures the ability of the person to voluntarily move their center of mass whilst they are standing in place. So the person is standing in the central box, and they have to voluntarily lean forward to move their center of mass with control. Now, this is what is known as the in-place strategies. So that is your ankle and hip strategies are covered with this test. But look at what happens to when the patient has Parky. They're stuck because of rigidity, because of bradykinesia, because of being unable to move to generate the motor strategy. Remember I said levodopa doesn't help you generate the motor strategy. It may improve the perception of the limits of stability, but the patient is pretty much stuck. Imagine this person trying to turn, shifting their weight laterally. For turning, this person would have to shift their weight laterally and swivel and turn. You can imagine this person is frozen, isn't it? Would lunges help this person move the center of mass? Absolutely yes. Because with these lunges, actually this is a warrior pose, but in a Tai-Chi class, but with these lunges, you can move the center of mass really well. You can go to the edges of the limits of stability, and you can learn how to generate your in-place and step strategies. So if I were to go back to my exercise slide and look at lunges, big steps is what you want. Okay, you can do lunges in several different directions. There's no limit to the exercises you can invent. but we need to know why we invent those. Now, this is a balance class that we conduct every Wednesday in my department. So I've been doing this for the last 4+ years, and we have a Parky class, and now we even do Lee Silverman's, specifically the Think Big program. But this is a general balance class for Parky patients, and here they are doing movements with interlimb coordination, where they're trying to move their trunk. One limb is protracted, flexed, rotated, and the other one is being extended and retracted, as you can see. So interlimb coordination is also a function of the basal ganglia, which is again impaired in Parkinson's. This reciprocal large movements, moving the center of mass, help people with Parkinson. Excuse me. Now, the boxing, the literature says you can do this with a partner, or you can even do this with in a boxing arena, but we really want our patients to be safe. So what I've shown you here is a sitting down example of a patient. The next challenge would be to do this with a person standing, in Romberg, with a person standing in tandem. Have a look at this. So now you see I'm going to increase the speed of the instructions. You saw that it took the patient time to catch up to my increased speed, but he eventually did. So speed, agility, position, challenging surfaces, challenging stance, all of this can be the next progressions for this. This would be reciprocal movements with attention, with executive function, with challenging surfaces. So this video doesn't come on to the PowerPoint. So I'm just going to step out of the PowerPoint for a minute and play it separately. This is a dual tasking video. So this video is for 2 minutes, 30 seconds. You notice small amount of freezing. So you saw how the individual needed to pay attention to what was happening whilst to my instructions whilst continuing to walk and maintain balance, whether turning or now imagine if this were an unsteady surface, the road, or outside in the environment with other environmental noises, etc., and the person had to be more attentive to other tasks. The basal ganglia is responsible, like I said, for multitasking and to be able to prioritize the task at hand that is more important for safety. In Parkinson's, this is impaired. So we have to train them for dual tasking, multitasking. Now, if I were to tell this person to listen to my instructions and then pick up things that I left on the floor, that would be an additional challenge. Now, to look at freezing. Briefly, freezing is something that occurs in narrow spaces because of the impaired visuospatial map. So it's important to have wider spaces. It's not always possible, but it's important to have wider spaces in in and around the residence of a Parkinsonian patient. It's also important to teach them how to turn. The weight shift for turning is very, very, very important. And hence, it's important to practice agility exercises or the anticipatory postural adjustments during situations where people freeze. So these agility exercises can be done, these quick lateral shuffles, grapevines, figure of eights, high knees are important to practice in narrow passages and on the turns. So now, it is also important, like I said, if somebody is going to have to keep their balance, they have to be able to generate an ankle strategy or a hip strategy or a step strategy. How do you teach them that? This helps in improving the stooped posture, it helps in improving their ability to balance, and helps in decreasing the fall risk. So simple, keeping two chairs and practicing leaning with a therapist, practicing the resisted step strategy. And this helps not only in generating reactive postural control, it also helps in anticipatory postural control, it also helps in posture, and also helps, of course, your core strengthening. Now, to talk about sensory reweighting, basal ganglia, like I said, are absolutely important in sensory reweighting, and because this is affected, they have impaired proprioception. So how do you help? Now, balance, as we all know, human balance. Sensory is seen largely in is taken care of by the three senses: vision, vestibular, and somatosensory or proprioception. Now, normally, proprioception looks after 70%, vestibular looks after 20%, and the normal person should be only reliant 10% on the vision. But our Parky patients are so visually reliant. If I were to show you our patient here, look at how she's looking down. Yeah, they are known to have impaired proprioceptions. How would you improve their perceiving proprioception better? You'll get them shades or dark glasses and get them to practice their balance exercises on an unsteady surface. And on the right side, you can even see this person trying to do the cross and jab movements with the eyes closed. So this is how you can, of course, you can progress this to a wobble ball, and this is not a safe way to do it. There's nobody around this person, but you need to have fall safety measures in place and always make sure that there is somebody close guarding. So just to summarize, as we come near the end of our discussion today, just to summarize, what are our 4 problems? I think I've repeated myself adequately. Sensory integration, anticipatory postural adjustments, motor agility, limits of stability, and these are the ones that need to be addressed. And we've discussed a whole lot of reasons why they need to be addressed and how they can be addressed by these exercise principles. Go out there and invent your exercises and treat your patients. Just before I end, I would like to bring to your notice, I'm sure some of you already know about it, but the Karolinska Institute has a high balance program. It is a high intensity and a highly challenging program, which is given to Parkinsonian patients over a 10-week period and helps in all 4 of these. So this is the program. Like I said, the references are in the back. This is week 1 to 10. And you can introduce various tasks to improve agility, limits of stability, APAs, and sensory integration. Here are the references. Please feel free to take a shot. I would like to thank you for listening to me. I think I'm right on time, exactly 1 hour. And
.5.
Yeah, I hope it has been audible and largely glitch-free. And thank you so much for the opportunity. I hope this has been as good for you as it has been for me.
Thank you, Ms. Poonam. Thank you, Ms. Poonam, for the wonderful session.
Thank you.
So the entire session, it is not only theoretical. You have just introduced a lot of practical aspects. Your slides interspersed with pictures as well as videos. So it was really a good session. So we all enjoyed it. Hope the participants would have also enjoyed the same. So I request the participants to post your questions.
Yes.
You can just unmute yourself and you please feel free. Yeah, please feel free to ask questions. There was one question from Ms. Meghna Mehta.
Yes.
Can you just, Meghna, if you can ask question, you can unmute yourself and ask question.
Hi, Dr. Poonam. It was a very wonderful lecture.
Thank you.
Hello?
Hello, I can hear you, Meghna.
Dr. Poonam, I had this question. So, when after levodopa is given to the patient, when the exercise session will be very effective? Like after how many hours?
Like we all know, in the on phase. The on phase happens anywhere between, It's very effective in the on phase.
Yeah, okay, thank you.
You're welcome.
Yeah, for your information, participants, before leaving, please note, feedback link is posted in the chat box. So you can feel free to give your feedback so that we can improve our webinar sessions. We can improve the quality of our webinar sessions in the future sessions as well. And it will be a good reflection for us as well as for the resource faculty. So invested to share knowledge with you all. So please respond to the feedback link and submit your responses before you leave this meeting. And request you all to ask questions if there is any other question from any of the participants.
So I guess that's about it. And thank you so much. I would like to appreciate Mahe, MCHP, Dr. Selvam for doing such a great job coordinating the Alumni Association. I would really like to say this has been an honor and a pleasure. I would like to thank Dr. Arun Maya and my alma mater. Thank you so much.
Ms. Poonam, it is equally a pleasure for us to host you as a resource faculty. So it has been a wonderful session, and thanks for sparing your time and sharing your knowledge with your alma mater. You are always welcome.
Thank you.
So maybe we can even organize more sessions together. So in the future. So
Lovely.
we are looking forward to you for your support.
I look forward to it. Very much look forward to it.
Thank you so much. I think there is not many questions coming from the participants.
Yes.
So if at all there is anything, I will pass it on to you for clarification.
Absolutely. Absolutely.
Yeah.
Absolutely.
So you can just, I think participants. So
stop sharing, and I will. I think I can.
I will reclaim my host.
Yes, absolutely.
I am not able to do from here. Can you just make me
I will
host?
try. I will try that. Give me a second.
And all this while I'm not able to record the video because I'm not the host.
Okay.
So
but
you are the only one who is recording.
It said it was recording, so it's still
recording by the host.
Yeah, it's still recording. Okay.
You can share the video to me later.
Yes, definitely. I'm just trying to make you the host. Please give me a moment.
Yes.
Can't see you. Should I end the meeting? Sorry. So sorry about this.
You have to make me host. You just against my name, you will find more option.
Yeah.
So you click more, then there will be make me host.
Yeah. Just a moment.
So that's what there are limitations to in each platform.
Yes, I agree. I so agree.
So unfortunately, we could not admit more than 100. There are many people.
I know there were a lot of people
waiting.
waiting.
Admit more than 100.
Yeah, and when I tried to admit more, my screen was hanging when it went more than 100. Yeah. I have made you the host. There you go.
Okay. Anyway, I will not be able to record anymore. So
I'll share whatever.
We have already ended. Yeah. Please share the video.
Yes.
And I will share the feedback with you.
Lovely. Yes, please.
So hope to stay connected with you.
Yes. Definitely.
Thank you so much.
Absolutely. Thank you so much. You've been a great host, and it was a pleasure interacting with you. Thank you.
Yeah. Thank you so much. Bye.
Okay. Yeah. Bye-bye.
Bye.